All right. Good afternoon, everyone. If you're in another time zone, could still be good morning. Welcome, welcome. My name is Reuven Lirov. I am the Chief Operating Officer here at ClinicMind. Joining me today is one of our very best, Jeremy Lee, who's our Director for Revenue Cycle Management here at ClinicMind. And we're glad you're here. And for those that are going to be reviewing the recording, looking forward to hearing those as well. Really, what we want to talk about today, most practices are losing revenue every single month. This is something that happens across the industry, not because of poor patient outcomes, not because of bad documentation, but really because of broken billing workflows. We've got claim errors that slip through, missed charges that never get captured, denials sitting in a queue, no one's following up, revenue that starts aging for 90, 120, 180 days. And today, we're going to talk about exactly how the billing cycle works, how it really should work, where the money tends to leak out, and how ClinicMind is built, purpose-built to stop it. So let's get into it. And I'm going to allow Jeremy for you to take over in just a couple of minutes. One of the things that I think is really, really helpful to set out here. So ClinicMind started out as a medical billing company. So we've been doing this over 26 years. And one of the things that's really unique about the way we approach this, as opposed to a lot of other players out there, is we're purpose built around that engine. Insurance claims are something that we've been thinking about, scrutinizing over, and improving and automating year over year. And like anything else, it's all about people, processes, and technology. So as Jeremy starts to talk about this, we want to keep those three things in mind. So Jeremy, off you go.
All right. Thank you, Reuven. Again, welcome everybody. Thank you for taking the time to join us today. Hoping that we can educate you and then answer any questions that you may have at the end. It kind of starts with, before you can fix anything, we have to understand the full picture. The billing cycle, to me, and I think to a lot of people in this industry, it really has 8 steps in the bill, excuse me, in the revenue cycle. At ClinicMind, we're built to support every single one of them. Every dollar you earn starts at charge capture, recording what was done, for whom, and at what code. The charge moves into claim scrubbing, checking for errors before it leaves your office. This is very, very important for us here at ClinicMind. We have a major rules engine that's built around our scrubbing, that our goal is to, when that claim goes out the door, that it's clean. We want to make sure that we've done all the scrubbing we can to decrease those denials and, to get the money in the door as fast as possible. From there, once it completes the scrubbing, goes into submission, sent to the payer electronically, then adjudication, payer decides what they owe. From there, the payment posting, money applied to the right claim, denial management, fighting back on every rejection, and finally, patient billing, collecting the patient's portion. We'll kind of talk about this a little bit more as we go, but the way that our system is built is that everything we do flows in that direction, in that way. And it's really built around not just supporting the revenue cycle in a whole, but also end to end. You hear that term used loosely in the industry. We support the whole revenue cycle. Okay, but some companies say that and they're like, but we don't really support the coding, or we don't support the patient billing. Our system truly end to end that we support. Excuse me. Our straight through billing process, what we call STB, is designed to keep every claim moving clean, fast, and forward through each of these stages automatically. Kind of going back, and I'm sorry, I have a habit of jumping around. So
I was just going to say, Jeremy, I think it's worth mentioning, as we move through this, ideally somewhat conversationally, it's worth kind of painting the picture of where we're headed. So as we go through today's conversation, we're going to touch on the billing cycle. We're going to touch on charge capture. We're going to touch on clean claims. We're going to touch on denial management. We're going to touch on accounts receivable. We're going to touch on a little bit more about how we are that complete loop and what's unique about the way that we go about this. And ideally, if you're already using ClinicMind, you're already experiencing a lot of this. But I can't tell you how many times I've had that experience where I talk to a client and they don't even realize that this thing is being done for them. And that's the reason why their KPIs look so good, which is where we'll close. We'll talk about what are the KPIs when it comes to revenue cycle management, because a lot of times, and Jeremy, you can speak to this as well, a lot of the times the concerns that you hear from practices are, my collections are down. the cash flow is not what it was 3 months ago. What's going on? It must be the billing. And those things are what we call lagging indicators. And so you generally have both leading and lagging indicators. So the question then becomes, okay, what are those leading indicators? And that's what we'll sum up with today. That'll be sort of the penultimate thing we'll talk about. What are those key metrics? What should they be so that you can go back after today, ideally, and take those KPIs, take those benchmarks, those targets, and then do a third column of where you're at today and get a better idea of, is this actually an issue with our RCM, or is a leaky bucket happening somewhere else?
Yep, exactly. Thank you, Reuven. And to Reuven's point there, with with our system and the way that we operate here at ClinicMind is, you know, we don't settle for the status quo. We're constantly looking like, how can we improve this? And we use every opportunity that our clients come back to us with what they brought as either an issue or a concern, and we address that, but we also look at, okay, how can we improve this going forward? And that really plays into every one of these 8 processes, even when down to the point of we send it back to our clients, they pursue their patient billing. We have statements built in our system. We have everything to support every touch of the workflow here. So, kind of going on to the charge capture piece of it here, if it's captured, if it isn't captured, it isn't billed, and that's something that I've been in this industry for 21 years now. And you hear that said a lot. Well, if you didn't capture it, you didn't bill it. Okay, but what are companies actually doing to fix that? It's one thing to say it, but how do you fix it? And that's where, we with our existing clients, new clients, we spend a lot of time up front in our onboarding process to make sure that we're capturing the codes that they're billing, that we look at their data, we look at their workflow to make sure, okay, where are you missing revenue? It's one thing to be a vendor and to be a partner, but it's another thing to actually step in and work with your clients to say, okay, you hired us to do your billing, but we're going to help you even more. We're going to show you where your practice is missing money. And we strive to do that. And a lot of that happens at the point of charge capture. Your front desk is, they're trying to get patients in and out. Doctors are trying to see new patients. And, sometimes there's just stuff that's missed. And, we have a lot of great tools at ClinicMind that, we use a lot of AI to help capture, things during the visit that catches those charges where they're not missed. It catches the coding, that really helps that part of the process to eliminate those charges missed up front. Because at the end of the day, if you don't catch them while that patient's there, or when you know, do the coding, you don't know about it. It's gone. It's revenue you missed. And, kind of the industry right now, we're seeing up to 12% of charges go uncaptured in manual workflows. And it's just, unfortunately, it's the nature of the beast is when a lot of offices are doing manual work, they're going to miss things. And that's where technology, automation, and AI comes into play. When they're all put together, it's a very powerful tool. And, that's what ClinicMind has spent 20 years building out. It's, charge capture, it's the foundation of every revenue cycle. It all starts there.
Do you find, Jeremy, when you talk to practices, especially during setup, what's the experience generally been like for you, for those clients coming over, talking about what it was like pre-ClinicMind, where they were previously? Do you find that, they're coming in with, a set of expectations around what the system can do? They generally don't know what they don't know. What's been your experience there?
My experience, Reuven, has been that most clients come in with very low expectations because they have had other software systems and other vendors that they've used, and they've went through what they would consider a nightmare process. And then once they start with our onboarding process, start seeing the system and the training, they're really blown away at ease of use and the things that we have taken into consideration and built out in our system. We have very, very positive feedback from new clients.
I was going to say that, my experience years ago when I was actually onboarding practices, this is a side thing, but interesting. Years ago, we had account managers that pretty much did everything around here. And I came up during that generation And I was, in that seat. And so we were doing all the training for our users and all of that. This is long, long time ago. One of the things, speaking to owners transitioning over, there's a lot of anxiety around data transfer, but also there's anxiety around the actual workflow,
Hmm.
adding the data in just day to day. How do I make sure the charges go in? Where do the charges go? How do I make sure I understand where the claim is at any point in given time so that I know, the claim is in process, or it came back, there's an issue with it, or it's stale and it came back and there's an issue with it, or before it even went anywhere, was there a P2P mismatch? Was there a P2D mismatch, right? Is there something wrong with the way that those codes were configured? Even more, sometimes you'll ask the question, it's like, okay, who does your coding?
Hmm.
Well, we have a different team that does the coding. Okay. Is that the most efficient way to do this? In other words, wouldn't it be easier and faster if when you did your notes, the system automatically configured your codes? In other words, it interpreted, right? It acted as a CPC. It acted as that role, because oftentimes we have offices come over who have billing staff. And one of the worries also is not just from the owner about billing performance, it's also on the staff itself. They're wondering, okay, if you guys can do all of this, then what am I going to do? And one of the things that I really liked about that experience was they don't often realize how much better their lives get, because that function, oftentimes you're splitting your time between the work of being a detective and the work of being an operator, of actually fixing issues. And so what you've developed over all those years as a biller in an office, or as somebody who held that responsibility set, is oftentimes it's somebody who wasn't a biller that kind of had to take over the reins. Suddenly they're freed up to do other things. So they're recalling patients, right? They're working on SOPs for the office. They're really office managing, because usually office manager that has to take over that role. Very rarely practices will put it on like a front desk person, which is extremely, extremely dangerous and just outside their scope. But sometimes a temporary necessity. On the flip side, you have a CPC who now has built this really nice investigative skill set that can be pivoted to way more impactful areas of the practice, right? You're now
Absolutely.
really good at picking up on where issues are, what issues exist in the practice. And suddenly, you're able to think, okay, the doc wants to, or the clinician wants to implement, this new technology, this new procedure, this new something. Well,
Mhm.
now you get to be the tip of the spear when it comes to understanding, how do we bill it? Is it, the clinician's going to be the one that determines whether it's right for the patients, but is it billable? Is it collectible? What is the PVA? What is the per visit
Yep.
average on this, so that we can figure out whether it's a worthwhile thing to do, not just on the clinical side, but also from a business perspective. And now, as the clinician, as the owner of a practice, or as a CFO, now you're making an informed decision from two perspectives: the clinical perspective and the financial and business perspective. I think that's really, really powerful thing that ClinicMind can do uniquely, but that is underpins so much of what makes RCM a critical aspect of what we do.
Absolutely. And something else I've seen too, Reuven, with, practices implementing our software is that, back to your point of that biller that was, really in the weeds every day. Their day was consumed with trying to fix billing errors and get claims out the door. Once we take that over, not only are they able to be allocated to other areas in the business, but I've seen businesses or practices patient collections start going up. Their patient responsibility payments that they didn't catch at the time of treatment, that now that billers got time to focus on calling those patients more to collect on those dollars. So, I've seen a big benefit and turnaround in that area as well. So it's truly, by implementing the right software, the right workflows, the right tools, it has a major downstream effect for practices. And one of the great tools that I really like with our system is our AI scribe. Um, you know,
Yep.
using our AI scribe to, as a doctor's treating a patient, it transposing and taking notes, and then being able to take what it captured and populating in other areas of the system. And Ruben, that may be something you could speak on a little bit. I think you know a little bit more about that area than I do.
Well, one of the things about AI Scribe that's so nice, is in principle about the unified practice approach, unified platform approach, is that you can put it all together, right? You can tie it all together, and it's all baked in. So instead of having things over here that then need to be manually redone over here, it becomes a much more seamless experience, right? So you AI Scribe a visit, And that AI scribe not only pre-populates your notes, but also starts to pre-populate your charges. And now, for example, your billing staff is handling the exceptions. Really, a lot of this is built around, are you handling the lion's share of the backlog, or are you handling the exceptions? And you really want to get to the point where you're handling the exceptions only. So only those claims that have staled out over a certain point that can't be automated, only those claims that have issues that require intervention, only those visits where charges haven't been entered, but to the people who are responsible for that. So much of that depends on workflow and things like that. But yeah, I mean, the fact that you can implement AI in a way that is not only robust, but careful. One of the big things with AI is it's a buzzword, it is a powerful tool, but it hallucinates. None of these engines are perfect. Um, some are better than others, but I just don't see a reality where these things, ever fully replace an expert. You know,
Right.
um, having I mean, someone like you running revenue cycle management at ClinicMind with hundreds of staff, the fact that it is an antagonistic relationship to begin with insurance companies, right? I mean, it's not like normal financial interactions where you're processing a transaction and that's the end of it, and Visa is totally with you, they transact and you're fine. Insurance companies are actively working against practices, right? They're actively trying
Yes.
not to reimburse. And now they're implementing AI to that end. So implementing AI can definitely help, but it has to be done in a very careful way because it is an adversarial relationship
Mhm.
between a practice and the insurance company. You are in this epic battle over time that you need to always be aware of. There is no, and oftentimes that's one of the things we do at the very beginning of any relationship with a practice is making it very clear, like, okay, we are joining you in this fight. We are joining you as part of your army here in the fight to get reimbursements consistently and at the rates that you deserve. So yeah, I mean, I think that's a big part of it for sure.
Absolutely. And to that point of, insurance companies implementing AI to fight not paying charges, it's up to us it's up to us in our system to keep up with those implementations. We have to implement new things in AI to battle back on those, or, companies that don't are going to fall behind. You got to be able to stay up and make that fight as well. This to me, one of the biggest areas outside of charge capture for practice is, clean claims. That is the biggest battle I think today with, insurance companies is things are constantly changing. Regulations are constantly changing. It seems like every year I was joking with a friend of mine last year at a HFMA conference, and I said, I feel like sometime our CPT codes, they just change them to confuse us because they want us not to get paid. I mean, that's how I honestly feel about it. And I've been on some board discussions about that. So, we strive to have a very clean claim rate. Our clean claim rate across all of our practices is at 97%. Um, I will never sit here and tell anybody we have a 100% clean claim rate. I don't think there's any company in the world that can do that
Well,
because
I
there's
think it also
always
depends
something.
on the practices too. I mean, practices also need to be a part of that equation. And anytime you have humans in the
Yep.
equation, yeah, totally reasonable.
Yep. And this kind of goes back to, I've been asked numerous times over, the last probably especially 10 years of like, can't billing be 100% automated? And, I just laugh at that because anybody that has done billing, you know, that that's never going to happen. Like you're going to have human interaction. And, with the clean claim rate, a claim that goes out clean comes back fast. In the story. You get it out clean, it's going to pay, you're going to have the money in your pocket fast. And with our system, then the way everything gets scrubbed before it goes out, that's what allows us to have that 97% clean claim rate.
Yeah. Yeah, 100%. If it makes sense, going through these KPIs as we go through. So clean claims, 97%, super important to be thinking about manual data entry, super important to be thinking about modifier usage, diagnosis coding, and preventing high rejection rates through making sure that things are set up at the beginning as cleanly as we can. I agree. In terms of denial management, if we want to take a look at that,
Absolutely.
yep, go ahead and switch this out.
Uh,
So
yep. So. Go ahead.
go ahead, Jeremy. Go ahead.
Yeah, I was just going. So with this, it's going to say denials. They're denials aren't losses; they're delays, and we work every single one of those. If anything gets denied, we're on it. We work those. We figure out what we need to do to get it overturned. And denials are not the end of the revenue story. They're just a detour. And we've got to figure out how to get that detour fixed so we can get those paid. But that only happens if you pursue them. 90% of denied claims are never resubmitted. And that's just think billers are so focused on getting new claims out the door that a lot of times those denials just sit in the back and they never get to them. No, that's not our process here. The way that we work, if it comes in denied, we're going to work it. It goes right in the queue with new claims to be worked at the same time.
Yep. Yeah.
So,
I was going to say
go
one
ahead.
of the things that's really interesting about denials that we take very seriously is clarity. Oftentimes, you know, so quick story. When I did my CPC exam, I went to school for clinical psychology at Rutgers, and I remember going in for my CPC, and the proctor for the exam, asked me, hey, are you a biller? And I said, no, I'm actually in school for my PsyM. And she said, oh my God, that's so great. I can't tell you how many times I've worked with practices as the biller where the clinician, when I use codes and I say things from a billing perspective, they don't know what the heck I'm talking about. And I said, listen, I definitely don't know how great I'm going to be at this. I passed my exam and all of that, but I think there's a oftentimes a built-in lack of clarity. Your point from earlier about how it seems like they mess with us just to mess with us. One of the things that we like to do is make it very clear, like, hey, a CO4 means this, PR96 means that, so that it's very clear the bulk of your denials are happening because you are making mistakes at the very beginning. And the best part about that is it's a conversation about workflow optimization. Now we're talking about, okay, if we know that 41.7% of your issues are CO4 errors, we can go in and suggest workflow changes, and we can collapse that 41.7%. And now we look at the next biggest area, right? And so in business, in Six Sigma and areas like that, we think in terms of this thing called Pareto distributions, where we look at things in that declining order, where the top 20% of our issues, are caused by the majority, a small subset, or the 80% of our issues are caused by a small percentage of our problems. I think it really bears repeating that level of clarity over this almost built-in level of confusion by
Mm-hmm.
insurance companies.
Yeah. And I think that's where with our full service that we have here at ClinicMind, billing is not a separate service offering. It's included with the work that we do, fighting those denials and appealing those. And, because that's money your practice has earned and it's just sitting on the table. And, we want to get that money. We want to get it for you, and with our specialized teams that we have here, along with our software, they do this every day as to where you as a practice, you may see 3 or 4 denials a day. So, you don't see that root cause of what's causing those denials as to where we see hundreds of them a day sometimes. So we'd be able to look at those and be like, oh, well, we've seen 100 denials across 40 practices. Here's the root cause and be able to fix that. And it's things like that we see that we don't just get that claim fixed and out the door. No, we're fixing the root cause of the problem. And whether that is updates in our system or if that's coming back to you all and saying, hey, we realize there's a coding issue on your end. Here's a change. Can you make it? Can you educate your staff to eliminate those denials? It's a partnership. And you've got to have those open lines of communication to be able to get to that point where you can make those changes and have everything flowing seamlessly like we want.
Yeah, without a doubt.
To this, AR is the health score of your practice. At the end of the day, you can look at any practice, you can look at any KPI, any dashboard, and what is going to drive your revenue is your aging and where it sits in your revenue cycle. For us at ClinicMind, that 0 to 30 days, that's a healthy spot. That you expect to see every claim there, but kind of come on top of that, we expect to see it. We always don't. Like right now, our average days to pay, I hadn't looked at it today, but it's around 18 days. from the day we submit a claim until we see payment come in the door. So we see the majority of our claims, they never reach that 31 to 60 day mark with our system because they're going at kind of full circle here. They're going out clean. They're getting paid quickly. There's no denials. So we see the claims drop out of that date range pretty quickly. And then, that next 31 to 60 day, that's kind of that point where you're going to closely monitor those. There may not be an issue yet. I think anybody that's done billing long enough knows, you start getting towards the end of the year, you see stuff kind of slow down paying sometimes, but it's once it hits over that 60-day mark that it's like, okay, there's action that needs to be taken here. Why are we not seeing the payments on these? With our,
Yep.
I'm sorry.
Yeah,
Oh,
absolutely. I think there's something really valuable about that from a cash flow perspective, right? Because oftentimes you're thinking about things from a point of sale perspective, because that's our normal day-to-day experience. You pay for a service at the time of the service, whereas with insurance companies, we often have this other relationship where, they're trying to delay payment as much as they can. Something that folks sometimes don't understand about this is it's not a function of a a built-in nefariousness. It's a financial decision that they're making at the cost of your finances. Why? Because at least half of the profit that an insurance company makes is made on what's called the float. And if you don't know what the float is the money that they don't pay you that they collect interest on by holding on to for at least 30 plus days. And so
mhm,
for every financial cycle, they're able to withhold your insurance payment. They make interest. Now, we know that oftentimes those percentages seem really small. Like your bank account, sometimes those percentages, you're like, that's not an amount that's going to, result in anything. But one of the things that we don't recognize is that insurance companies have volume. And so when you're managing billions of dollars in insurance reimbursements for providers, and you can hang on to half of that for 30 to 60 days, now you've got, yeah, maybe it's only 0.5%, but 0.5% on billions of dollars every month. So suddenly there is this baked in incentive to say, well, how can we make this more complicated? Because the longer I can hold on to this money and not pay the clinician, the longer we make more money on basically nothing. We're not doing any work. It's like we're making free money. Now, from the clinician's perspective, suddenly you need to think, all right, now how do I plan from a cash flow perspective for these kinds of delays? Because I'm providing the services at this clip and I'm not getting reimbursed for sometimes up to 60 days. In other words, my costs of this cycle are bleeding into the next cost cycle, but I need to make payroll this cycle. So now you need to start thinking about, again, these become lagging financial indicators where I need to build up a backfill of reimbursements. In other words, there is an initial inertia that needs to generate itself here in order to make sure reimbursements are coming in. And now looking ahead becomes more and more important. By the time you're thinking about your collections this month or last month, you're already months behind. And that's
right,
something really important for folks to understand. If you're thinking about your cash flow being low this month or last month, you're way behind already when it comes to next month and the month after, because those months are largely spoken for already.
right. And I don't know about you, Reuben, but I'd be happy with one half of 1% of $1 billion.
Yeah, and
That's
that and $1 billion isn't the whole thing. I mean, a
right.
billion, it's billions. I mean, if you think
And
about the size of these companies, yeah, it's ridiculous.
yeah, you just give me half of 1 billion and I'd be happy. But that you make a good point there, Reuben. That's their goal. Insurance companies don't just make their money off of premiums. They're making their money off of money that they're holding and earning interest on. You have to have the right company, the right software to be able to fight those kind of things. And with us, this is every morning I have a routine and I'll share with everybody. I'm a morning person. I'm up at 5 o'clock. I get my coffee. By 5:30, 5:45, I'm at my desk while it's still peaceful in my house. And the first thing I look at is our KPIs. Like the number one KPI I go to is our AR over 120. That drives what I'm going to do for the day. I look at that and I'm like, okay, are we good? Do we have, someone at risk? And when I say look at our AR over 120, I look at it from a global standpoint. And I also look at our top 10, top 50 clients that have the highest and the lowest to, be able to tell my teams, hey, We need to dig into this. There might be an issue here, especially if we have several in the same state. That's telling me, okay, there's probably an insurance issue here that we need to fix. But that's just one more tool that we have in our arsenal here to, be able to manage this inventory. The industry kind of benchmark, and it's crazy to me, but the industry benchmark for AR over 120 is to be in the 15 to 20% range. And that's crazy. We live by a motto here with our KPIs that we measure according to, world-class standards. That's where we want our teams to be. And I can proudly say that our RCM team here consistently has a AR over 120 below 10% across the board for all clients as a combined as a whole. So, and if I see that get over 10%, okay, what's going on? And we don't do that just by throwing more people at the problem. We do hire staff when we need to, but we throw more technology and ideas at the problem to be able to solve that. I learned a long time ago, if you just throw bodies at a problem, you're just creating more problems, because the more people you have, the more problems can come up. So, like I said, if we need people, we'll put people there, but let's try to fix it with technology and automation first. Right.
Yeah.
So, and kind of the RCM workflow at ClinicMind, it's a loop, it's not a line. Anybody that refers to revenue cycle as a straight line, like, I'd run from them, because it's not. Revenue cycle, it's a continuous loop, and this loop can go a couple times before it actually completes. I think most of us know that. You could get to the point, if you've billed, it denies, you're starting your loop over again. You might need to go back and check eligibility. You might need to make sure that you didn't miss anything at charge capture and start that process over again. With our system, with our system, it easily allows for that. It's not like, wow, we missed something, we've got to go through all these manual processes again. No, most of them it goes through without you even knowing about it. Or our RCM team picks it up. When it comes back and rejected, they're gonna grab that claim. They're going to figure out why it was rejected. If the system couldn't identify the issue, they're going to get it fixed. They're going to resubmit it. So, it takes that burden off of your staff and you all to fix those problems. That's what we're here to do. And if our system doesn't do it, our people will. And it's definitely a two-pronged approach with RCM. Is we strive for our system to do as much as possible, but when it comes to our people, by having a system that's so advanced, so automated, the use of AI, it allows us to employ people that are really high-level individuals that, when these claims come back, it's not a guessing game of, oh, well, I just started in this industry 6 months ago. I don't know what to do. No, my billing team, our team here, most of our leadership on that team is 15 plus years experience. So, they're very high class individuals that's done this for a long time. And I think that really sets us apart from a lot of our competition. We don't have a constant churn with our teams here. They're here. They know the system. They know how to fix things. I'm very fortunate when it comes to that at ClinicMind, of being able to have that type of team underneath me that, they can get the work done and they can identify the problems.
I think that's absolutely correct. I mean, the cyclical nature of RCM, it's interesting to me to hear stories from folks who, for example, hire credentialing companies, pay them thousands of dollars as a one-time fee. They either do the job or they don't, and they think that the story's over. And one of the things that we know is that credentialing is also a cyclical experience. It's all of these processes are repeat processes. There is no such thing as a one and done. And having a platform and a team behind you that understands that, at almost a cellular level, I
Mhm.
think is a really critical, and even the way that our relationships with our clients, our practices are set up, it's baked into the very way that we organize ourselves around how we succeed or fail together. Um, and that kind of sync up where we're really succeeding when you succeed together or struggling when you struggle. One of the things that will always happen is deductibles will renew and insurance collections will decrease temporarily. And that's something that we should all absorb together, something that insurance companies will never do. They
Mhm.
will collect no matter what. They don't care. They don't appreciate seasonality that clinicians go through. Having an organization on your side that appreciates those kinds of things, and aligns themselves behind that, I think is a really crucial part, and something that I think folks should always be looking for is, like, are these folks really aligned with our best interests? And is that something they say, or is that actually something that they live?
Yeah.
From the invoice to process, are they actually living what they're saying?
100% agree, Reuven. I think I've heard it a lot in this industry. I had a vendor, I had a partner that, they got everything set up. It was great. And then once we got going, it took weeks to get answers from them or to get something fixed. And, that's just that starts a relationship off bad. And, I think that's kind of where our full circle RCM here really shines, is that today we're talking about RCM as a whole, but the company as a whole, we're there from beginning to end. And when I say end, it's not end of onboarding. It's end of the day that you decide you're going to retire and close your practice. We're here from start to finish. But with our RCM, it's built out to where you don't have to have other companies do pieces of it for you. We have full credentialing that we offer for our clients. We have eligibility verification built into our system. We do the submitting, patient statements, the follow-up. Like, there's nothing that you would ever have to go outside of our RCM software to have another company do for you, with the exception of collections. But even at the collections, we have a couple preferred vendors that we can refer you to. So other than that, our system will handle 100% of that RCM workflow. You know, and I kind of got ahead of myself there. I have a habit of doing that. Kind of going back to what I was saying, one platform, every tool you need to build cleaner and collect faster. We have our Claims 360, that's our full RCM service. Our Credit Edge, that's our credentialing that we do. And the Credit Edge is, it's the same as our RCM. It's technology backed by a team that we can do. Our AI Scribe, as Reuven talked about a little bit earlier, that can, capture that visit and scribe that into the notes. Our ClinicMind Pay, that's our integrated payment processing. The My ClinicMind patient portal and statements. We have our own patient portal that patients can log into. It's not another company that they're using. It's our portal. We have apps for it. However I pictured it when I first come to work at ClinicMind and was told we have all of this. I was like, I've been in this industry a long time, and I've seen very few companies that can support all of this. I was proven wrong very quickly. We do have all of this, and we fully support it, including our virtual front desk and our patient hub. These are some of the features and services that we offer with our platform. So I don't know, Reuven, if there's any specific one you want to touch on there.
No, I think that's good. I think that's
right. That's the end of our presentation today. My goal with this was, not only to talk about ClinicMind. If you all can't tell, I'm very passionate about the company. I've come to this company and do not regret a day of it, because I've sat where you all are before. I've been on the billing side. I've worked, the vendor side. I've been in the hospital setting. So, I can truly appreciate what this company has done with their software and their technology. So, I really encourage anybody that, if you have questions, that QR code that we have on the screen, you can schedule a no commitment consultation with us. Can't promise that you'll get me directly. You won't get to hear my Southern accent. But if you specifically request me, I might try to join. But we'd love to talk to you all, even if it's, we're having this problem right now. Is there a solution that you have for it? If it's outside of what we talked about today. We have a development team that loves to develop new things. So, if there's something that we didn't show you today, we might have it. If not, we'll build it.
One thing that I would stress here as a sum up from my perspective is you can't improve what you don't measure.
Mm-hmm.
And having obviously ClinicMind, we give you the dashboards to track all of this. If you're working with us today, you've gone through that during your training, those dashboards, all of that. If you're not, we'd love to show you. But if I were to choose 6 KPIs that I think everyone should take away and make really at the core of what makes billing successful, you want to be thinking about your net collections rate, your NCR. You want that to be at or above 95%. For us, it's 97% or above. Those are our targets. and realities. But from an industry standard perspective, generally you're benchmarking yourself against the MGMA, the Medical Group Management Association, but there are other groups as well that stat these KPIs. But as an industry average, you want to be at or above 95%. Clean claim rate at or above 94%. Again, you know ours is 97. First pass resolution rate, we didn't talk about that in detail, but that is something that you want to be tracking at or above 85% of claims should pass on the first attempt. And again, in our case, our reality is much higher. These are all industry standards I'm giving you. Days in AR, you want to have your days to pay be less than 35 days. This one you can't stress enough because it's a cash flow indicator. The more of your dollars that are waiting beyond 30 days, even 35 days is too long in my opinion, but the more of your dollars that are waiting over 30 days, the more, as the owner, obviously, cash flow is a problem. How am I going to pay my staff? How am I going to pay the electricity? How am I going to pay the water? All that is critical.
And to that point, not to something, Reuben, that a statement that I made incorrectly earlier. I said that our days to pay have been averaging 18. Last 2 months, they've actually been at 12. So just wanted to myself there.
Keep being wrong in that direction. I'm a big fan. No, and that's one of those things, to the degree that it can be seasonal, sure, but the reality is, do we have world-class KPIs? Yeah. And it's almost like business as usual for us because not only do we put the right technology in place, the right processes in place, but as you can tell from folks like Jeremy, it's the right people in the right seats. Again, collections rate, clean claim rate, first pass resolution rate, days in AR or days to pay, denial rate, and then your AR over 120 days. Now, one thing that you want to keep in mind, oftentimes we actually talk in AR over 90 days. Why? Again, you're always choosing between leading and lagging indicators when you're talking about KPIs. For me, as a Six Sigma Black Belt level 3, numbers define my existence. When I think about performance, again, as Jeremy alluded to earlier, a practice may do thousands of claims, but we process millions of claims, and on a very regular basis. What that means is that we now operate in an environment of Sigma levels of, the number of things you are measuring is in the millions. And so now what used to be okay at 90%, when you get up into the millions of things, whether it's little widgets that you're making or claims that you're handling, a single percentage can create a wildly negative experience for a client, for a practice, for a set of practices. And so the numbers are king and queen. The numbers rule the universe. And knowing what your benchmarks are, knowing what your targets are, those things, if you're a biller, should be stapled or, well, maybe not stapled, but stuck on your monitor in front of you all the time. And you should know them at the drop of a hat. If you're a practice owner and you walk by your billing staff and you just ask them offhand, hey, what's our NCR right now? Your billing staff should just know that number. That should just be something, and not because they sit there memorizing it, right? But because they're always looking at it. They're always looking at, and it gets even more detailed than that, really. So like, for example, I'll often ask Jeremy, we use level 10 meetings as part of our cadences. And one of the things we'll ask is, hey, what's our biggest contributor to high days in AR by payer? Who are our biggest red flag payers right now? Is it United Healthcare? Is it Blue Cross? Is it Medicare? Who's creating the biggest challenge for us right now by payer? Now, when you get into that, then you ask the question, and again, that's something that Jeremy should just know off the top of his head, right? Not because he sits there memorizing it, but because he's in it, he's living it, he's looking at it all the time. And if you're a biller, that's the reality. You're looking at it, you're living it all the time. The challenge is, how do you surface the concerns related to those things at the level of an owner who, as soon as you start talking CPT codes, their eyes can gloss over? You know what I'm talking about. They start to just kind of like, you know what I mean? They're like, okay, I just wanted the problem fixed. I really like Medicare, Medicaid. I don't even understand the difference. Just call the insurance company and get the claim paid. It's like, well, listen, first of all, yeah, it's like, that's not how this works. The problem is you appended the wrong modifier to your CPT code when you generated your charge, and it got denied. So now we need to submit medical records. Now we need to submit a corrected claim. Now there's all this confusion. So what billers often need to learn how to do is how to wordsmith all that detail in a way that an owner can hear it. They can receive that information, right? That ability to hear, all right, listen, here's what's going on succinctly. There's an issue with the way you guys are doing your notes today. I'm not telling you how to document clinical encounters. That's not what we're here for. But what I am saying is the way you're documenting your clinical encounters at the end, when you do your code selection, it's causing red flags to get thrown up here. And what I need you to do is consider this change to your process. I need you to consider doing this instead of this. And so now you're bringing a solution to a practice, something that in Six Sigma, we call this plan, do, check, act, PDCA. The idea is that what we do is we distill the information such that it's immediately clear what problem you're trying to solve. It's immediately clear the impact of solving that problem, and it's immediately clear what the options are to the owner or to whoever it is you're talking to. And so now there's the waste of time is minimized, and the issue of what gets lost in translation starts to go away. But if I had to, yeah, I think those are critical, what we call in Six Sigma, critical to quality.
Yes.
So Jeremy, how do we want to sum up? How do we want to round this off? We've never done this before, if anybody couldn't tell.
This is our first one, so we're new to the whole game here. I wanted to take some time, the last few minutes we had, to answer a couple questions. I seen some pop up in the chat while we were going. Actually, I just seen them pop up a couple minutes ago.
I like it. Yeah.
So let's see. So what do we have?
Denial rate under 5%.
Yes, 100%. Yep, that is our goal.
Denial under 5%, and that should be the industry standard. You really want your denial rate to be under 5%. Yeah.
So let's see. Looks like Brad, you had a question. Is there a dashboard for AR trend versus a snapshot in ClinicMind? So our dashboards are, very, trying to think of even how to describe them. They're amazing.
Yes.
The thing about it, if we don't have it, we'll build it. But yes, we do. My dashboards that I look at every day, every one of them are trends. Like I don't look at just snapshots. And like we have them that are real time. So you're not looking at previous days. Like it'll truly show you the trend of what you want to see. Like I was just looking at one this morning for a practice that I wanted to go back and see what their trend looks like for the last 3 years for a specific payer. Had it up within like 10 seconds. So to your point, yes.
Yep. Can ClinicMind build custom scrubs for individual practices? So here's what I would say. I would say no, but there's a reason why I would say no. The reason I would say no is that we don't think about our clients as individual practices. We think about our clients as part of a whole, almost like the human body, in that it is like a shared immune system. When you ask for a scrub, the first instinct we have is not to say no. Our first instinct is to say, is that an issue that's coming up in more than one place, or is it just happening for you? Still not done there. Let's say it's just happening for you, okay? Now we dive deep and we ask, how often is this happening? And we go, is this a scrub we need, or is it a workflow issue that needs to be addressed? So in other words, do we actually have a scrub need here, or is it just that there's a user error happening? And that's totally normal, right? And we address it. Now, what if there is something that needs to be scrubbed differently? We need a new, what we call validations in the system, right? We have millions of them that Jeremy's L3 team is responsible for maintaining. Every time a claim is submitted, it hits that rule set of millions within seconds, and those claims get scrubbed. So what happens? Well, we decide, yeah, this scrubbing rule makes a lot of sense. Thank you so much, Jasmine, for discovering this issue that we didn't know, millions of claims were processing and we never ran into it. So we now discovered it, but guess what? Everyone gets to benefit from it. So now these antibodies are now available throughout the entire lymphatic system. The whole set of practices across the entire country now gets to benefit from Jasmine's discovery. That's an incredible thing. That's an incredible thing. Suddenly your impacts, and honestly, maybe this, I'm biased because of my training, but that's why we do what we do. It's the impact across, it's nice to help a patient. It's nice to help lots of patients, but imagine having an impact across the industry. That's incredible. That's often to me, like why I get up in the morning, like paying my bills is critical. Raising my kids is critical, but what's the impact in the wider world too? Right? That's another thing I'm thinking about. And so the fact that somebody can come in, make a change that suddenly allows a practice to thrive and see more patients that they couldn't see before because their cash flow allowed them to bring on another clinician that they couldn't before. My God, the far-reaching effects of that we often don't know, and we never know in the moment, but are often way further than we think.
And it's truly satisfying for us, Reuben, to see, talking about building custom scrubs. We do so many of those and things like that in our system that our clients don't even know about, but it's making their life better on a daily basis. But we're constantly doing that. And we don't, we don't reach out to our clients and brag, say, hey, I put a new scrub in and it's going to help you with this. We just do it because it's the best for our practices, for our clients.
Is the non-allocated part under the financials something we can affect in-house? Like, are we taking the correct steps on this? Can I edit the validations in Supernote? So a couple of things I'll touch on here, just because we're running out of time. I'm going to be as succinct as I can. So I apologize in advance. I know I'm verbose, so sorry. So is the non-allocated part under the financial something we can affect in-house? Yeah, you can tie and allocate payments individually. You can do this. We generally train our offices to allow the system to allocate based on oldest balance owed, because we want to make sure the bookkeeping is always as accurate as we can, or as up to date as we can. But you can allocate specifically. What I would say there is you want to get with chat, you want to get with our team and do a one-on-one screen share session, have them walk you through, because both things are possible. You just want to make sure which workflow, again, makes the most sense for your practice. And can you edit the validations in Supernote? So there are some validations in Supernote. Again, I would get with our chat team on that. But we're about to release actually our new version of the Supernote built into 2.0, ClinicMind 2.0. And it's actually going to be way cooler than what Supernote was in the past. Very, very similar, but way more up to date, where actually, yeah, you'll be able to have way more control over validations than today. Supernote today is our previous EHR incarnation, for those who don't know, and it very powerful in its day. I was actually involved in building it, coming off of our previous incarnation called XMR. And it has a lot of really cool things where you can do the note on the left and the summary is coming, the note itself comes up on the right. There are limitations because it's a hard-coded documentation system. So there's not a lot of editing you can do. But in the new ClinicMind 2.0, there's a lot of editing you can do. So if you haven't already, I highly recommend. No, updates are coming out across the board, but I mean, yeah, the lion's share of updates are coming out for 2.0 because that's where the future of ClinicMind is. So, it's not like we're not updating the rest of ClinicMind. It's actually one of the benefits of our platform is for 26 years, we always maintain multiple versions of the platform. So we've got, the legacy version, the current version, the beta version, the preview version. So you can see what's coming before it's out. If you run into an issue, you can go back to legacy. So we don't have a plan to stop supporting in that way. So I mean, updates come out absolutely across the ecosystem.
Yes, they do.
Yep.
All right, not to cut Reuben off, but if I don't, he'll keep talking.
Forever.
But I wanted to tell everybody, thank you for joining us today. Those of you that are existing clients, we truly appreciate your business. Those of you that are not current clients, would love the opportunity to talk to you. Kind of one promise that I want to leave with everybody today. Our promise when it comes to our system is revenue without friction. That's our goal. Revenue without friction. So, I'm going to close with that today. I hope everybody enjoyed this. We had a great time with you, and feel free to reach out to us to discuss anything further.
Interested in becoming one of our thousands of satisfied customers? Contact us.